Hi guys, hope you all done your NEET-PG 2022 very well, and now you are relaxed, and now you can recollect what are the questions you attended and what are all the options, and this will give you a confidence. And also those who are attempting planning to attend the next PG, NEET-PG. Okay, those who are planning for the next PG also will have an input about this, how the types of questions are framed or like these things. Okay. So those who have done the things well, okay, so congratulations, advance wishes to all of you. And definitely you all will be getting your PG seat of choice in your respective colleges, in the colleges which you have dreamt for. Okay. So how, if you ask me like how the responses from the students about this May 22 NEET PG, so it's a mixture of responses. Like actually, like most of you felt that this paper is like a relatively bit tougher on the tougher side, and and some of you felt that it's a moderate paper. And if you ask me, like it is like a mixture of things. Like you have repeats, you have new topics, you have straightforward questions, you have controversial questions, you have one-liners, you have image-based questions, and you have mostly like this clinical scenario questions. So it is a mixture of the things. Actually, those are given the last NEET, and also this INI-CET also will agree with me. Like it is a mixture of the things, but yet some of you have felt that actually it is little bit the question standard is more a little bit tougher than the previous NEET. Okay, but still definitely like the things, it's a decent paper which you can definitely attempt, and it can get a good score. So it is a decent paper. So coming to like a pathology based things, like if you ask me like how about the pathology based related questions are asked. So from the core pathology, actually, as usual, as we discussed in the last year also, from the core pathology, the questions were almost like more than 25 to 27. And the related topics, actually, some little bit with the pathology knowledge, you can solve up to some even 33 or 34 questions. So as always say, year by year, the weightage of the pathology questions are increasing. And as we saw in the last INI-CET also, like the same thing, like more questions were asked from the genetics. So genetics and other questions were equally distributed between general path and little bit of more of hemat, and also from the systemic path. So come on guys, so now we'll solve the first MCQs. Like these are all the things actually are based upon the recall, based upon your recalls. And if any of you feel that the options or can be changed, or these things can also put it in the comment box. Okay, so also we would like to say that actually most of the questions out of these questions, I can show you with the things. Actually, most of the things were asked from the ADrPlexus based workbook, actually, what we teach. So most of the things are actually I can show you with the screenshot, and most of the things are from the video lectures and the workbook based sessions what we teach. Okay, so let us now see the first questions. Which of the following is a autosomal recessive inheritance? So, like if you see that last INI-CET also, okay, so 2 weeks before you're given the INI-CET, so in that also there's similar type of things, like to ask the some kind of pattern of inheritance was asked, and they're asked to identify the disease. So here the options given are achondroplasia, cystic fibrosis, Treacher-Collins syndrome, and Huntington's disease. And it is a guys, it is a quite straightforward questions. And if you remember the list of autosomal recessive disorders which we teach in our ADrPlexus, actually it is, you can remember with the mnemonic ABCDEFGHI is albinism, ataxia, telangiectasia, beta thalassemia, and we have also dealt with this cystic fibrosis. Is cystic fibrosis is an autosomal recessive disorders. Okay, so out of the list, actually it is a quite straightforward question. And out of the all the things which is mentioned here, cystic fibrosis is the autosomal recessive pattern of inheritance. Okay, and we have dealt with the list of all autosomal recessive disorders in our workbook. Okay, in our workbook. Then the next second question, and this I used to always used to insist, and this is also one of my favorite questions. So every session, actually, I used to insist on this question, and exactly ditto the same question was asked. And the question was actually a 10-year-old child presented with the bone lesions and hepatosplenomegaly. Yes. So from this bone lesions and hepatosplenomegaly. So bony lesions and hepatosplenomegaly in a child actually points to something like a lysosomal storage disorder. So it is a lysosomal storage disorder. And what further the examiner gave the clue is the bone marrow aspirate showed the cells as shown in the image. Yes. Actually, the similar kind of image was given in the exam. And what are the images? Actually, in the images, what you could see is the large cell. These are all the large cells, and if you can see the cytoplasm, and this cytoplasm is giving you an appearance of a crumbled tissue paper appearance. Yes, it is a crumbled tissue paper appearance, and with this crumbled tissue paper appearance, that is, you can make a diagnosis of a disease of Gaucher's disease. Yes. Gaucher's disease. So this is a case of Gaucher's disease, and we have identified it with the appearance of the cells, crumbled tissue paper appearance. And as guys, as all of you know that this Gaucher's disease, the enzyme deficient is glucocerebrosidase. Glucocerebrosidase, yes. And obviously, actually, we have dealt with this thing in our workbook-based sessions also. And similar question, actually, I have given you in the test and discussion session also, like the typical session, like bone pain and hepatomegaly and all these things actually we have discussed with this crumbled tissue paper appearance. Yes, the same question was asked. And coming to the next question, actually it is little bit of clinical related things, but still the histopathology appearance was given here in this question, I hope. Yes, the patient presented with fever, night sweats and cough for 2 weeks. Yes, cough for 2 weeks. So here there is a history of fever and night sweats and a cough for 2 weeks. And X-ray revealed bilateral hilar lymphadenopathy. This is something very characteristic, bilateral hilar lymphadenopathy. And further, to support the diagnosis, the examiner has given bilateral facial weakness and pain in the right eye. Like what does this suggest? Bilateral facial weakness suggests like actually facial nerve palsy. And also, pain in the right eye may be because of the uveitis, and the examiner may be giving us about the history of this Hereford syndrome. Yes, Hereford syndrome is nothing but it is a variant of the sarcoidosis. Yes, sarcoidosis. So this is also like the clues are straightforward and nothing, no controversy in these things. And histopathology also confirmed with this mononuclear infiltrate. That is the loss of the lot of the histiocytes. And you can see the non-caseating granuloma. If you can remember, okay, sarcoidosis, you will get non-caseating granuloma and the palisading granuloma. Yes, palisading granuloma. That is the histiocytes are arranged in a palisading manner. So this is something characteristic of the sarcoidosis. Is, and the correct option here is the sarcoidosis. Yes, though fever, night sweats and cough can be seen in tuberculosis, actually the duration here is less, 2 weeks, and it is actually this bilateral hilar lymphadenopathy and facial weakness, okay, need not correlate with the tuberculosis or a lymphoma. Obviously, like bronchogenic carcinoma will not have the similar picture. Like you can rule out this bronchogenic carcinoma. Actually, histopathological examination will show the malignant cells. So here they are given it as mononuclear infiltrate. So we are ruling out the bronchogenic carcinoma also. Okay. So the correct option here is the sarcoidosis. Sarcoidosis, yes. And obviously, actually, we have dealt with these things in our thing also, workbook also, about the sarcoidosis and the bilateral hilar lymphadenopathy. Yes, they're exactly the same word, non-caseating granuloma. Okay, so all these things actually we have discussed in our workbook. Okay, okay, yes. Now moving on to the next question is mutation of a single nucleotide change resulting in a stop codon is called as. Okay, so what the examiner is saying, so it is a mutation of a single nucleotide change. It is a mutation of a single nucleotide change. It is a type of point mutation. And what does this change results in? This change results in a stop codon. So what is this type of mutation is called as? Like if you can recollect what we have discussed in our workbook, again exactly the same thing was asked. If you can see from our workbook based notes, actually we have mentioned it as the types of point mutations, and I have told you about the silent mutation. Silent mutation means like when the nucleotide is changing and there is no change in the amino acid. Say for example, see this, when there is a normal thing, TTC codes for lysine, okay, but when there is a single nucleotide change and that is not and that is resulting in the same amino acid, you get it what is called as silent mutation. That is, the mutation doesn't change the sequence of the things and the amino acid getting is the same thing. But what we have told is like it is a stop codon. The mutation results in a stop codon. Yes, usually UAG is a stop codon, and such point mutation leading to a stop codon is called as nonsense mutation. Nonsense mutation. There is the other type of mutation also we dealt, that is the missense mutation. Missense mutation is nothing but it can be of two types, conservative and non-conservative. So conservative missense mutation is nothing but like if the resulting mutation codes for an amino acid which is biologically similar to that of the original amino acid, you call that as conservative. That is, the amino acid which is now the new amino acid which is now formed due to the mutation is similar to the biologically previous amino acid, is that you call it as a conservative mutation. And what do you call it as a non-conservative? Obviously the resulting amino acid, when it is totally different from the original amino acid, you call that as a non-conservative missense mutation. Okay, so coming to this question again, guys, and the examiner has asked about the nucleotide change, and that nucleotide change has resulted in a stop codon. So the option here we have to choose is the, I hope you all choose to this nonsense mutation. Nonsense mutation. Yes. Yes. And the age-old question, and I can say that this is one of the most repeated topic. Okay, about the Men's syndrome, I always used to insist in my class that actually there will not be any exam without this Men's syndrome. Okay, like that much of importance. Okay, some almost in every exam, like you, they'll get some components regarding this Men's syndrome. Okay, so which of the following is not a component of Men 2B? And the examiner has given the options of parathyroid adenoma, mucosal neuroma, morphonoid habitus, megacolon. Okay, morphonoid habitus and megacolon. Okay, so if you can recollect the components of the Men syndrome, which I have told in my workbook, these are the notes for my workbook. And actually, I told you to remember about the Men one, that is the Wormer, about the 3-piece parathyroid, pituitary, and pancreatic adenomas, and foregut carcinoids, angiofibroma, lipoma, and pheochromocytoma. Men 2A, which is called as a sequel, you will get pheochromocytoma and parathyroid hyperplasia or adenoma, medullary carcinoma, and 3 of the blastomas. Yes, neuroblastoma, nephroblastoma, retinoblastoma, and Hirschsprung disease, and cutaneous lichen amyloidosis. Okay, then coming to Men 2B, pheochromocytoma will be the medullary carcinoma and thyroid carcinoma, morphonoid habitus, and mucosal neuromas. Yes, and also megacolon also will be there. Okay, so what is the odd man out here is the parathyroid adenoma. So parathyroid adenoma usually will not be seen in Men 2B. Okay, so if you can see from this tabular column, this parathyroid adenoma is seen as a component of Men 2A, that is the Sippel syndrome. Sippel syndrome. Okay, so and actually there's some of you were of the opinion that it is a toxic megacolon, like that. If it is a toxic megacolon, actually toxic megacolon is usually seen in the ulcerative colitis especially, so usually will not come in Men 2B. Okay, but if the option is megacolon, then we have to choose the option as correct answer here as the parathyroid adenoma, which is not seen in Men 2B. Okay, yes. And again, this is also the one of my favorite topic, that is which of the Warburg effect? Yes, it is a straightforward question actually, which is asked in your exams. Which of the following is the reason for the cancer cells using the Warburg effect? Okay, so in my class, if you see, refer to my notes, actually in the ADrPlexus, actually we have mentioned in the workbook that actually about the Warburg effect. Okay, so cancer cells have to somehow make some effect, some mechanism to derive its energy. Okay, they are rapidly proliferating cells and they are always in need of some energy, Okay, so what they'll do, actually, these cancer cells will convert most of the glucose to the lactate, even in the presence of the ample oxygen. Even in the presence of the ample oxygen, they will go in for anaerobic glycolysis. Yes, so because why this is done? Because actually such things will be the mode of metabolic intermediates that are needed for the production of the cellular components of the neoplastic cells. So the cancer cells will produce these intermediates, so that is needed for the growth of this cellular components. So the correct option here is the cancer cells using the Warburg effect, because this is useful to make intermediates to aid survival. So the cancer cells want to survive. How they want to survive? They want to survive somehow. They want to derive its nutrition. So by this anaerobic glycolysis, they produce that intermediates, and the anaerobic glycolysis will help to make them to produce the cellular components so that they can grow and proliferate. Okay. So the Warburg effect main uses this only to produce intermediates. Okay. And it is not to increase ATP or to avoid aging or the less glucose uptake by the cancer cells. Actually, these cancer cells will have a glucose hunger. Yes, cancer cells will have a need of glucose, and this is called as a glucose hunger. Okay, and you can recollect these things from our workbook. Okay. Then another thing about another important repeat question, that is all of the following are true about neutrophil extracellular tract except. So, dear students, actually, the question is asked. Actually, it is in the recent edition of the Robbins, and one of the most stressed topic in our sessions, like the neutrophil extracellular tracts. Okay, so if you could remember from our sessions, okay, so neutrophil extracellular tracts are nothing but actually the neutrophils extrude their nuclear material out. Okay, like in the form of a fibrillary materials, in the form of a fibrillary meshwork, like octopus. Like octopus traps the microbial agent, these extracellular fibrillary materials, what they will do, they will go near the site of a microbial agent and they deliver the toxic substances. So they deliver the antimicrobial agents. Okay, so this helps in the easy killing of the bacteria, In this process, actually, the nuclear material is extruded out. It is a nuclear material. Nuclear material is extruded out, and after that, the cell dies. Okay, and this is phenomenon is also called as a beneficial suicide. That is after the suicide, that is after the death, there is a beneficiary suicide. That is the antimicrobial agent is released into the near the bacteria, and the bacterial agents are killed. Okay, and I also told you to remember about the arginine, which is an important nucleic acid. Okay, informate that may be a future source of a question in future exams. Okay, so how these questions are framed in the exams, if you see the trend of the questions, actually there will be one question asked in one topic, and then the next exam tangential topics around the same question will be asked. So there may be a chance that in the next exam they may ask you about the arginine, which is the most important amino acid in the neutrophil extracellular traps. Okay, so I told the nuclear material is extruded out, no? So whenever the nuclear material comes, and this nucleus may act as an antigen for the autoimmune disorders, and this may elicit the autoimmune disease. That also you should keep in mind. Okay, so now coming back to our question under the options. This is seen in sepsis, yes, obviously. So in sepsis, microbial agents will be there, and to kill that microbial agents, actually this neutrophil extracellular tracts mechanism will be activated in sepsis. Yes, and it is an interaction between the neutrophil with the bacteria. Obviously, like octopus, I told you, it will catch the prey. Like the neutrophils will go near the bacteria. Yes, antimicrobial products are released at the site. Obviously, this is also the correct option. So what is the wrong option actually here is the involvement of the mitochondrial DNA, and which is the wrong option here. Okay, involvement of the mitochondrial DNA. This is the wrong option. All the other things are true. Okay. Then coming to this question, actually there are two questions asked in the exam related to the aging. And I hope you all remember that aging which we saw in our workbook. Okay, so aging, actually there is a Hayflick limit. I hope you remember. Hayflick limit is nothing but a number of cells. Number of times a cell can divide is fixed. That is, it can divide up only up to the 60 to 70 cell divisions in their lifetime. Okay, so guys, don't get confused between telomeres and the telomerase. Telomeres is something, actually these are all the short repeated sequences. Telomeres are something, but these are the short repeated sequences at the tip of the chromosome, that is at the ends of the DNA, at the end of the chromosome. So what happens, these telomeres in somatic cells, after every cell division, the telomere length is shortened. Okay, so this telomere length is shortened. Okay, this telomere length is shortened after every cell division. So what happens after some 60 to 70 cell division? The telomeres are totally lost. The telomeres are totally lost, and the cell stops its division. Okay, so telomerase is nothing but it is an RNA-dependent DNA polymerase. So it is an enzyme. ASC. So telomerase is an enzyme. So what is the function of the telomerase? It actually rejuvenates the telomeres. Okay, it rejuvenates. Okay, it increases the length of the telomeres. Okay, so in cells like stem cells, germ cells, and also in cancer cells, the telomerase activity will be more. Yes, in cancer cells, in your stem cells, and in your germ cells, the telomerase activity will be more. Then that is the reason for the longevity of these cells. Okay, so coming back to the option question here, which of the following is the true about role of telomerase in aging? Okay, so increase in telomerase activity in aging? No, this is a wrong option. Actually, with aging, what happens? The telomerase activity is decreased. Okay, so this is a wrong option. So increase in length of the telomeres with aging, the second option says. This is also a wrong, because with aging, I told you that the telomeres length is shortened. Okay, now we are left with the two options, that is a decrease in telomerase activity in aging, and telomerase decreases the length of telomeres. Obviously, by this time you will be able to tell me that telomerase increases the length of the telomeres, yes, and this is the wrong option. And the correct one is the telomerase activity decreases in aging. Telomerase activity decreases with aging. Okay, so this is the correct option here. Okay, so the same thing actually we discussed in our workbook. And now students, actually the other question with the aging is regular exercise for 30 minutes daily, which of the following delays the process of aging? Which delays the aging? Like the elixir, which delays the aging. So exercise for 30 minutes daily, reduced level of antioxidants, more reactive oxygen species, and a restriction of calories by 30%. And some of you said that the sirtuins was in the option, so I put it in the bracket since because only some of you recollected that sirtuins was there in the options. So if you can see these things, we'll go with the B option, reduced levels of antioxidants. Yes, but please remember, when the antioxidants are increased, it delays the process of aging. Yes. Okay, so it is the aging occurs because of the oxidative stress. Because of the oxidative stress, the aging occurs. So actually antioxidants decreases the oxidative stress, thereby delays the process of aging. So when the antioxidants levels are low, actually aging is accelerated. Aging is accelerated. So this option is wrong. Okay. And more reactive oxygen species means what? More oxidative stress. So more oxidative stress means it accelerates the process of aging. So this is also a wrong option. Okay. So here we have to choose between the two options, regular exercise for 30 minutes daily and restriction of calories by 30% and sirtuins. And dear students, actually we can agree to some extent that regular exercise for 30 minutes daily, it is one of a healthy behavior. But Robbins clearly says in the chapter of the aging, if you can read through the words of the Robbins, it clearly says that exactly the same word, calorie restriction and sirtuins delays the process of aging. Okay, so out of the two options, if we have to choose one option, means it is better to go with the restriction of the calories by 30%. Yes, obviously, because Robbins exactly clearly says you the same exact sentence. Okay, restriction of calories delays the process of aging and sirtuins. Okay, so and also like we have dealt with the so much things about the sirtuins, especially the sirtuin 6. Okay, this can be, since sirtuins are the new things, actually this can be asked in the next exams. Tangential questions can be asked. Okay, so sirtuins increases the longevity of the cells by decreases the metabolic activity. Yes, obviously when the calorie restriction is there, metabolic activity will be decreased, obviously. Yes, and the sirtuins also decreases the apoptosis, and that increases the protein folding, and it decreases the reactive oxygen species, and it promotes the DNA repair. By all these mechanisms, the sirtuin 6, especially sirtuin 6, accelerate, actually increases the longevity of the cells, and delays the process of aging. Okay, so guys, please remember, sirtuins and calorie restriction delays the process of aging. This is also actually we have discussed, and we have also discussed about this accelerated aging, that is the progeria syndromes and all these things in our book. And another favorite question, that is a 35-year-old male presented with a painless, slow-growing neck swelling. His cervical lymph nodes were enlarged, and surgery was done, and the histopathological image is shown in the below. Which of the following is not true about the lesion? Yes, so it is a male patient, and painless, slow-growing neck swelling. So neck swelling, now first thing you will think of is a thyroid lesion, and the lymph node also enlarged. So neck swelling plus lymph node enlargement. Like sometimes this thyroid swelling, like can present without any thyroid swelling, with first lymph node enlargement as the first feature, that is aberrant lateral thyroid, you can say. Okay, so if you can see this thing, it is a clear-cut one about the clear chromatin, ground plan chromatin, and this is across the image similar to this kind of is given in your exams, and what you could see is, and you can see the cross section of the papillae. Okay, you can see the cross section of the papillae, and this very characteristic papillae is this, having a central fibrovascular core, and more important thing is the nucleus with a clear chromatin. Yes, clear chromatin, and this type of nucleus, yes, all of you know that this is a ground glass chromatin. Okay, ground glass chromatin, or orphan-anni-eyed nucleus. Yes, orphan-anni-eyed nucleus. Okay, so this is the same thing actually we have discussed in our workbook, and if you can see in your test-based discussion also, I have given you one question about this papillary carcinoma thyroid. Okay, and exactly the same thing actually I mentioned in the question, like FNAC was done and the malignancy was suspected, and I given you the similar image. And we have discussed also about the papillary carcinoma, and also you will all remember that papillary carcinoma will be a radiation exposure will be there, and it is encapsulated and well circumscribed, and because of this it carries a very good prognosis. Okay, very good prognosis. And also it is a diagnostic features is the nuclear features, that is a orphan-anni-eyed nucleus, and the nuclear grooving, and also the pseudo inclusions will be there. And this papillary carcinoma thyroid is prone for lymphatic spread. Okay, so now coming back to the options with the image, and with the open chromatin, that is a ground glass chromatin, and the orphan-anni-eyed nucleus, we have made a diagnosis of papillary carcinoma thyroid. And let us see this options one by one. Nuclear features or characteristic of this tumor is, it is a right option. Nuclear features or characteristic. The tumor carries excellent prognosis, obviously, and the rapid spread to lymph nodes. Yes, actually, this papillary carcinoma commonly spreads to the lymph node. This is a correct option. Okay, and FNAC is not diagnostic, is a wrong option, because actually in most of the times, actually when a patient presents with the neck swelling, actually this FNAC is a common investigation which is done, and most of the cases actually papillary carcinoma can be easily diagnosed by the FNAC itself. Okay, it is a straightforward. If the, especially if the yield is high, it can be easily diagnosed in a FNAC. So FNAC is a diagnostic mode of investigation in this papillary carcinoma thyroid, and this is the wrong option here. Okay, so I hope you all recollected what we have discussed in our workbook. Okay, the same FNAC. Okay, yes. The next question which was asked is the 35-year-old female presented with joint pains, fever, oral ulcers, rash, oliguria, and hematuria. and the urine shows RBC cast. Okay, so what you will suspect, especially a female patient of a reproductive age group presenting with a joint pain, fever, oral ulcer, rash, oliguria, and hematuria. Urine also showed RBC cast. Okay, so though this RBC cast, this hematuria can be there in post-streptococcal glomerulonephritis, RPG, and messenger capillaries. And if you can see, post-streptococcal glomerulonephritis, usually the age group is not fitting into it, and usually this RPGN or messenger proliferative will not fit into these options. Why the patient should have joint pain, fever, or oral ulcer, rash. Okay, rash is also an important clue. So ruling out these three options, we are making a diagnosis of a lupus nephritis. Yes, this is a case of a lupus nephritis. And if you can remember the things which I told you to remember the features of the lupus nephritis, okay, so you would have recollected this: joint pains, fever, oral ulcers, rash, etc. Okay, and I have also given you a similar question in your test-based discussion. Exactly the similar things like a peripheral edema, female presented with a peripheral edema, chest pain, rash, and elevated serum creatinine, and the histopathological image. Okay, so and and also I have highlighted you that wire loop lesions. Yes, wire loop lesions are characteristic of this lupus nephritis. Yes, and I have asked you at the time. I have asked you about to diagnose the most specific antibody, and you have chosen it as Smith antibody. Okay, so and also we have dealt in our workbook about the different types of the classes of lupus nephritis. That is, a class 1 is minimal mesangial, class 2 is mesangial-proliferative, class 3 focal lupus nephritis, class 4 diffuse lupus, and class 5 membranous, and 6 is advanced sclerotic. Yes, and wire loop lesions are commonly seen in class 4. Yes, this we have discussed in our workbook. Okay, so the next question is, a 15-year-old boy presented with massive edema and anasarca. Which of the following is true about this condition? Yes. So a boy presenting with a massive edema, that means what? A massive proteinuria would have occurred. Okay. And this result in a massive edema and a generalized edema anasarca. So commonest cause for a massive proteinuria and a nephrotic syndrome. So it is a massive edema, so it is a nephrotic syndrome. So commonest cause for a child to present with a nephrotic syndrome, all of you will be knowing that this is a minimal change disease. And now we have to think like what is the true about this condition. Okay, so it coming to from these options, a non-selective proteinuria, no, it is a selective proteinuria. And a light microscopy shows effacement of the food process of podocytes, and this is also a wrong option. And it is not the light microscopy which shows this effacement of food process, it is the electron microscopy. And it is common in the children, and hence this option is also ruled out. And if you could recollect from my notes in our workbook, like actually I told you, more than 90% will respond to the steroid. More than 90% will respond to the steroid, and it carries an excellent prognosis. Okay, so I hope you all remember why it is called minimal change disease from the notes, that it is actually there is no immune complex deposits. It totally appears normal by light microscopy only. In electron microscopy only you can get this type of changes, hence only it is called as minimal change disease. So the correct option is it responds well to the steroids, and it carries a very good prognosis. Actually more than 90% response for minimal change disease responds well to the steroids. Yes. Coming to the next question, it is a similar kind of questions about the asking about the high risk, which of the following strains of the human papilloma virus is categorized as high risk. If you all remember that actually HPV 6 and 11 will be causing this anogenital warts. Yes, condyloma acuminata. Okay, it is a anogenital warts, and it is the HPV 16 and 18. Okay, HPV 16, that is a human papilloma virus 16 and 18 or the high risk viruses which are implicated in the carcinoma cervix. Okay, so the answer is 16 and 18, and I hope this also you will remember from what we have dealt in our workbook. Okay, so if you can see, like from my notes, actually most of the things have come from, it's like 100% hit. See this, actually here also we have discussed about 16 and 18 high risk HPV. And the next question is actually, it is also discussed in our workbook. A 28-year-old male presented with malaise and icterus. A serological examination revealed HBs antigen positive, anti-HBC IgM positive, and HCV RNA is negative. What is the most likely diagnosis? What is the most likely diagnosis. Okay, so with the history of malaise and icterus jaundice, actually, we can make a diagnosis of hepatitis, and the serological markers tells you clearly that HCV RNA is negative. HCV RNA is negative, and this rules out your option C and option C. Okay, option C. Then both option B and this thing is similar, but here if you can see D and D, sorry for that. It is actually a chronic hepatitis C virus, chronic hepatitis C virus, and this option is also rolled out. Okay, this option is rolled out. If you can see, HBsA antigen is positive. That can be because of a vaccine induced also. But what is a clue here for your diagnosis is anti-HBC IgM. Okay, so if you get IgM antibody positive, then it is a clear-cut indication that it is a acute infection. Yes, so IgM, it is an acute infection, and it is a HBV, so it is a hepatitis B virus infection. Acute hepatitis B virus infection. Guys, this is a very interesting and very repeat question. Okay, constantly asked in your last NEET INI-CET also. This type of question was asked. Okay, and if you can remember, actually in your test-based discussion, I have given you the similar type of questions to solve, and exactly the same thing. Actually, I have given you anti-HBC antibodies or negative, and IgG antibodies. In that case, actually, I told, okay, it is a more of a light of similar questions. Okay, so the next question is a child with a knee pain, swelling. Child presented with a knee pain and swelling, and the peripheral smear images findings is shown in the below, and X-ray findings are suggestive of a lytic lesion with the sclerotic borders along the radiolucent areas. Okay, so what does this suggest? Okay, the lytic lesion with the sclerotic borders along the radiolucent lesions actually points towards a diagnosis of a osteomyelitis. Okay, so the child from the X-ray image, we came to a conclusion that the child is having a osteomyelitis, and actually, what is the child is having? The child is having a bony pain. Okay, bone pain, joint pains, and what is the clue the examiner is giving you is the peripheral smear finding. And if you can see the peripheral smear findings, actually, what is so striking is actually it is the sickle cells. Yes. So from this, actually, it is a case of a sickle cell anemia. Okay, and other things also you can see these nucleated RBCs and also the target cells. Okay, and also the target cells. Okay, so this is a case of sickle cell anemia, and all of us will be knowing that sickle cell anemia, the most common agent causing this osteomyelitis and sickle cell anemia is the salmonella. Yes, so out of the options, the correct one is the salmonella. And about this thing also, we have discussed. And one more thing actually came from the sickle. The other thing which came from the sickle is the child presented with a history of hand-foot diseases similar to this bony pains, and it is a sickle cell crisis. Okay, the small sickle cells will occlude the small vessels of the digits, and it was for 6 months. And the other history which was given is the recurrent chest infection for the past 2 years. Okay, so this is a case actually. Hand-foot disease is one of the important clue we should know, because icterus, it can be there in any of the hemolytic anemias. Okay, but the clue is the child is having a recurrent chest infection. And another important thing is HbA2 and HbF is elevated. Both HbA2 and HbF is elevated. So with this, actually easily the other options like anemia of chronic disease or autoimmune hemolytic anemia we can rule out. And the thalassemia is also ruled out because actually classically the history of hand-foot disease and repeated chest infection, if it is there, actually definitely it points to a diagnosis of sickle cell disease rather than thalassemia. So if thalassemia is there, what the thing is the examiner would have given you about the abnormal facial features and also about the history of repeated blood transfusion. History of repeated blood transfusion, abnormal facial features would have been there in the history. Then we would have chosen a diagnosis of thalassemia, but those things are not there. And repeated chest infections and hand-foot disease favors a diagnosis of sickle cell anemia. Yes. And the same thing for sickle, actually, we discussed a lot about the sickle in our image-based discussion. Yes. And the next one is the very important question again, repeat topic. A 30-year-old male met with a road traffic accident, and he had a lot of multiple fractures of the long bones. On initial admission, he was very stable, but 2 days later, he developed severe dyspnea, petechiae, and loss of consciousness. and the examiner asked you like what is the most likely diagnosis. Okay, so obviously if you could recollect from our workbook, actually we have discussed the same thing, and the diagnosis of such a thing like when there is a patient presents with a multiple fracture of the long bones, okay, long bones, and after that the initial period will be uneventful. Okay, so initially the patient will be stable. So later, say for example, after 48 hours, you may present with a dyspnea, severe chest pain, okay, and also petechial rashes all over the body. Okay, so this is a case of a fat embolism. So the marrow particles, the fat marrow, okay, that will be gaining entry into the torn vessels and will be reaching the lung, resulting in the symptoms of this fat embolism. Okay, I hope you remember what we have discussed in the workbook regarding this image and the fat globules and the stain for fat, that is the oil red O. Okay, so typically I told you during my class that it is 1 to 3 days after the injury the symptoms manifest. Okay, the symptoms manifest. And if you could recollect, actually we have discussed also the similar, I have given you in your test-based discussion exactly the same history I have given you in the test-based discussion. Okay, so please, I hope you all recollect that what we have discussed in our test-based discussion. Okay, so multiple fractures, stable condition, initially severely dyspneic. Okay, so the fat embolism, I hope you remember these things. Okay, so the option here we have to choose is the fat embolism. Fat embolism. The next question is, 25-year-old male presented with a fatigue. His complete blood count revealed a hemoglobin of 9 gram per deciliter. His male, hemoglobin 9 gram per deciliter, definitely anemic. Yes, anemic. And MCV is 60 femtoliters. Yes, 60 femtoliters MCV points to that it is a microcytic. And RBC count is actually 5.2 million per cubic mm. This is why actually many of you have struck and many of you told that we don't know like how to proceed when the RBC count is 5.2 million. Okay, and this examiner also given you a clue that the peripheral smear examination showed features of microcytic hypochromic anemia. Yes, that obviously you know. And I hope you all remember that what we have discussed from our sessions about the differential diagnosis of microcytic hypochromic anemia, the similar symptoms actually we have discussed, and the features also of the peripheral smear also we have discussed in the workbook. And you all remember the major differentials for this microcytic hypochromic anemia is the iron deficiency anemia and the thalassemia. Okay, so coming to these 2 points, hemoglobin and MCV. Okay, it can be less in both in iron deficiency and the thal. Then how we will come to a conclusion? Okay, so there comes the rescue is the Menzer index. Okay, so what is this index? Actually, what is the formula for this Menzer index? Actually, yes, it is nothing but MCV by the RBC count. Okay, MCV by the RBC count. Okay, and if you can see what is the MCV here, it is 60. And it is the RBC count is 5.2. Okay, so if you calculate that 60 by 5.2, almost it comes around some 11.53. Okay, 11.53. So what is this interpretation from the Menzer index you have to know is if the Menzer index is less than 13, you have to make a think of the thalassemia. And if the Menzer index is more than 13, okay, or even 14, you have to think of iron deficiency anemia. Okay, iron deficiency anemia. So in our scenario, actually we made a Menzer index that we found out that it is 11.53. Obviously, it is less than 13, and this Menzer index favors a diagnosis of thalassemia. So thalassemia, what will be the next investigation? So it is the HbA2 levels. Okay, so to estimate the HbA2 levels, it should be elevated in the thalassemia, and this is the option. Okay, so you have to apply the concept of Menzer index here. Okay, to come to a conclusion. Yes, and the next question is a patient presented with the swelling in front of the neck and fatigueness. Patient had a swelling in front of the neck. Yes, now only we saw swelling in the front of the neck. Please think of it as a thyroid swelling and a fatigueness, tiredness. Yes, obviously the examiner also gives the other clue. The examination revealed the features of hypothyroidism and anemia. So hypothyroidism and anemia, what you will be getting is in the hypothyroidism, you will be seeing this macrocytes. Okay, you will be seeing the macrocytes. Okay, so here iron deficiency anemia is ruled out, and I think like some of you have marked it as megaloblastic anemia. Please, that is not a correct option. When you get macrocytic anemia also is there in the option. Yes, you get macrocytic anemia only in this thyroid disorders, and megaloblastic anemia will not be a feature. Macrocytes means actually only the RBCs. See this thyroid diseases, actually only the RBCs mainly will be looking very big. But in megaloblastic anemia, what you will be getting is the macroovulocytes. Yes, in megaloblastic anemia, what you will be getting is the macroovulocytes, and in thyroid diseases, you will be getting macrocytes. So the examiner gives you a history of thyroid disease with anemia, so you have to think of a macrocytic anemia. I hope I clearly distinguished these things in our sessions using this macroovulocyte when I dealt with this image-based discussion. Yes. The next is a very repeated question. Actually, this is actually we are all aware of this thing from our undergraduate days itself. That is the naked picture was given and the naked eye examination of the CSF of a patient who presented with a headache. Yes, the patient presented with features of meningitis, and the CSF examination was done by lumbar puncture examination, and the test tube itself showed some appearance. So, with this appearance, the examiner asked us, like, what is the most likely diagnosis? Okay, so if you can say, I carefully see this thing in this image, actually, this is something called as the cobweb formation. Cobweb formation. Cobweb formation. Okay, I hope you remember from our notes exactly the same thing I told you from our notes, that it is the CSF in TB meningitis will be having this cobweb formation. Cobweb formation is nothing but the strands like things in the bottom of the test tube. Okay, so this is something very cobweb formation was characteristically given in the image in your question, and this classically points to a diagnosis of a tuberculous meningitis. So guys, please remember tuberculous meningitis will be having CSF examination on gross appearance, will be having the cobweb formation. Yes. Yes. The next one, quite favorite for all of us, like 40-year-old female presented with a dragging abdominal pain. Yes, 40 female dragging abdominal pain. And obviously, you will be thinking of the splenomegaly. Yes, and actually the image of the peripheral smear is shown, and the genetic abnormality is seen in this patient. Okay, so the examiner given you the image similar to what we have discussed in our image-based discussion, like what we had in our workbook. See this thing and see this. You will be getting a varied appearance of the myeloid series. Okay, with different stages of the different cells in the myeloid series, like you have this neutrophil, eosinophil, and basophil. Neutrophil, eosinophil, basophil, and also you will be getting this myelocytes. Okay, and I told you in my discussion that this appearance is called as a garden party appearance. So the examiner has given you a similar image and asked you, like, as he has not asked you directly what is a diagnosis, instead he asked, like, what is a translocation. Obviously, all of us will be knowing, remembering that in CML, in chronic myeloid leukemia, with this myeloid series, preponderance and basophils is increase in the basophils. Actually, the diagnosis is CML, that is a chronic myeloid leukemia, and the Philadelphia chromosome is the thing which you should remember in the 3ML, and Philadelphia chromosome, the translocation is T9 and 22. T9 and 22. Yes. Then the next one is the testicular biopsy in a 30-year-old male evaluated for infertility. The semen analysis showed azoospermia, and the biopsy of the testis showed the histopathological findings as shown in the image. What is your diagnosis? So basically, it is a case of infertility, and infertility usually testicular biopsy will be then that is an indication for the testicular biopsy. And what you can get here in this thing, another clue is semen analysis showed azoospermia. Azoospermia means totally absent of the sperms. Okay, totally the sperms are absent. And also the biopsy of the testis showed this thing. So what a similar kind of image was shown in your exams. And you can see the seminiferous tubules. Okay, you can see the seminiferous tubules where the spermatogenesis is something arrested. Okay, you are not seeing any sperms. Okay, so only the semen analysis showed the azoospermia. Okay, so but what you could see in this testicular biopsy is that is the you can see the only the Sertoli cells. Okay, only the Sertoli cells, only the nurturing cells, only the Sertoli cells alone are there, and the spermatogenesis is not occurring. Okay, and also other feature is the interstitial cells of Leydig is present there. Okay, is prominently seen here. So definitely you can rule out this orchitis and intratubular germ cell neoplasia from these options. And I think most of you got confused between atrophy of testis and Sertoli-Wernicke syndrome. Actually, when you think of your infertility, and usually it is a clue that actually the sperms are not there, okay, with the further supported by the fact that azoospermia. So atrophy of testis will not be coming to your first thing when then there is a case of when you're evaluating for the infertility case. Okay, so infertility case because absence of the sperms as evident by the semen analysis, azoospermia, and from the history and from the picture image also it is given an image of like a tubules with just only the Sertoli cells. So definitely it is only the Sertoli cells. So only it is called as Sertoli-Wernicke syndrome. So out of these two options, Sertoli-Wernicke syndrome will be the best option to choose rather than the atrophy of the testes. Yes. And this is another question actually which they have given. Identify the marked structure given in the image. Actually, the examiner has given you a similar sort of image, and actually you can see what you can see is actually you can see this or the acini. Okay, this is a glandular structure. Okay, this is the glandular structure, and if you could remember, these are all the serous acini. Okay, and in between these glandular structures, you can see a ductular structure. This is a ductular structure, and you can see what is something like this. Okay, something like this. Okay, so out of the definite options, okay, definitely this is not a glomerulus. In glomerulus you will not be seeing this acini, and lymph node also you will not be seeing this acini. So you can get stuck up with these two options, salivary gland and islets of Langerhans. If you can see the structure of the pancreas, okay, structure of the pancreas, this is the acini. Okay, this is the acini, and this is the typical islet of Langerhans will be looking like these things. Okay, so in salivary gland, though this acini and gland can be there, a similar sort of structure will not be there. Okay, so what is focused here is the structure of the pancreas, and what the arrow is pointing out is the islets of Langerhans. So the correct option here is the islets of Langerhans. Yes. And similar, one more very interesting question. A 38-year-old female presented with an ulcerated nodular growth of 0.3 mm. Okay, sorry, 3 mm. 3 mm noted at medial canthus of the eye. The histopathological image is shown below. What is the most likely diagnosis? Okay, a similar sort of histopathological image was given in your exams, and what you can see in the from the image, okay, and from the history itself, it is a very important clue. Nodular growth and medial canthus of the eye. Yes, near the medial canthus of the eye, nodular growth definitely will be antenodal means striking, and you would have got the diagnosis. Further, to support the diagnosis, actually you can see, compare it with the image. Okay, so what you can see is that in the dermis, you can see the nest of the basaloid cells. Okay, in the dermis, what is shown is the nest of the basaloid cells. And another very interesting thing is these basaloid cells, the periphery are showing this palisading arrangement. The periphery are showing this palisading arrangement. That is a parallel arrangement. And also you'll be getting an artifactual cleft. This cleft, okay, cleft between the stroma and the nest of the basaloid cells. Okay, so definitely this is a case of a very classical finding of a basal cell carcinoma. Yes, both the histology also favored, and also the history also favored this thing. Okay, and if you remember from our workbook, actually we have discussed the same thing, basal cell carcinoma, and we have discussed about the rodent ulcer and basaloid cells palisading arrangement about the artifactual cleft in our workbook also. Okay, so now, and this is a question actually in few times back in the NEET-CET also such question was asked. A patient presented with the intraoperative bleeding, and the possible results of the intraoperative investigation done as shown in the image. What is the name of the investigation? Is actually it is a patient somewhere telling that there was a history of some disease, liver disease, but actually it is a generalized a patient with the bleeding during the table. Okay, so we have to do the investigation on the intraoperatively. So intraoperatively we have to assess the bleeding, and we have to say that whether this is a bleeding disorder, it is a defect of the platelet, or it is a defect of the the clotting, and immediately you have to ask for the blood product needed. You need what cryoprecipitate or fresh frozen plasma, like actually any clotting factor. The things, all these things actually you have to assess immediately. So it is a dynamic investigation that should be done. And the images actually what they have shown is the different types of the interpretation of the graphs. And these graphs are pointing towards the various findings which are seen in the investigation of thromboelastography. Okay, so TEG, that is PEG, you shortly call it as, and it is a dynamic investigation which actually tells you about the various phases of the thrombus formation. Okay, thromboelastography. So various phases of the thrombus formation and the maximum amplitude of the thrombus, that is the fibrin clot, and also the phase of the fibrinolysis. So it is a graphical thing, and based upon the any change in each phase of the thrombus formation, fibrin clot formation, the graphs can be interpreted. Okay, so the examiner has given you these various possibilities, and this investigation is the thromboelastography. Yes. Then, as straightforward from the lysosomal storage disease, actually, I always used to say that lysosomal storage disorder, some of the examiners' very favorite topic. Okay, this lysosomal storage disorder, like you can see from this exam itself, already on Gaucher's disease have come. So the second question is the child presented with the hepatomegaly and mental retardation. Hepatomegaly and mental retardation, and macular examination revealed cherry red spot. Yes, cherry red spot, very favorite. And first thing foremost, you will think of the cherry red spot in a child with mental retardation and hepatomegaly. That is the Tay-Sachs disease. Yes, Tay-Sachs disease. I hope you remember the things which we discussed in a workbook about the Tay-Sachs disease, the different types of Tay-Sachs, classic, infantile, juvenile, and the late onset. Okay, I hope you also remember about the cherry red spot which we have discussed in our things. And the electron microscopy is something very characteristic of this Tay-Sachs disease. You will be getting the old configuration of the distended lysosomes. This is something very characteristic of this Tay-Sachs disease. Yes. Then the next question is, an 8-year-old child presented with recurrent episodes of diarrhea, steatorrhea. Further investigation showed HLA-DQ2 positivity. Which diet should be avoided in this child? Yes, actually it is a child presenting with diarrhea and steatorrhea. So child with the diarrhea and steatorrhea, and what you will be usually suspecting, you will be suspecting a malabsorption syndrome. Yes, the history of diarrhea with the steatorrhea points to a diagnosis of a malabsorption syndrome. And what is the most important clue the examiner is giving you is the HLA-DQ2 positivity. Yes, it is the HLA-DQ2 positivity is the most important clue. And obviously this HLA-DQ2 positivity will be knowing the diagnosis as the celiac disease. Yes, celiac disease. And obviously you all know that it is a gluten hypersensitivity disease, and where you will be getting the exaggerated response to the gluten containing food products, and resulting in the total villus atrophy and increase in the intraepithelial lymphocytes. Okay, so all these things we have dealt. And now what will be asking the patient to avoid? We will be asking the patient to avoid the gluten diet. I hope you remember the bro. Yes, bro mnemonic, no? Barley, rye, oats, and wheat. You should avoid in gluten in this celiac diseases. The same thing actually we have discussed in this thing, and actually I highlighted you about this actually DQ2 and DQ8 in our workbook. Okay. And this is something very interesting. A patient presenting with a history of recurrent fever, hematuria, histopathological examination of the polypoidal lesion in the bladder revealed basophilic inclusion body. Okay, and some people were saying that the lesion, the polypoidal lesion, were in the trigone of the bladder. Yes, that can be the. And what is this basophilic inclusions? This basophilic inclusion, and the image of similar things was shown in the image was shown, that is the basophilic inclusion, and these are called as the Michaelis-Guttman bodies. Okay, these are called as the Michaelis-Guttman body. And these Michaelis-Guttman body are characteristic of the malakoplakia. Okay, malakoplakia. So malakoplakia is nothing but it is a case of malakoplakia is a defective in the bactericidal activity of the macrophages. Okay, so the improperly indigested macrophages will be accumulating with the all these iron particles and proteinaceous substances, and they will be forming a lesion sort of things in the things. Okay, this is something like a xanthoma. Okay, so more more of this, the patient can also present with a fever and hematuria. Okay, fever and hematuria. Fever is a clue. Okay, and some of you may be asking me, so why this is not a transitional cell carcinoma? Because it is a polypoidal lesion in the bladder. Yes, obviously, polypoidal lesion in the bladder. One of the differential diagnoses will be transitional cell carcinoma, but and hematuria can also be there in the transitional cell carcinoma. Agree, totally agree. But the history of recurrent fever. Okay, the history of recurrent fever and the histopathologic examination, basophilic inclusion body. Okay, tilts the diagnosis in favor of the malakoplakia, where you'll be getting that is a phagocytic defect in this macrophages. Actually, that points to a thing of gives rise to this recurrent fever and the basophilic inclusion bodies. Okay, so this is a case of a straightforward case of malakoplakia with this Michaelis Cutman bodies. Yes. Then primaquine given to a patient followed by hemolysis, and the examiner asked you deficient enzyme belongs to which pathway. Yes, primaquine, the antimalarial agent, would have caused that oxidative stress, and the enzyme G6PD, that is the glucose 6-phosphate dehydrogenase, is the enzyme which protects the RBCs from the oxidative stress. And in the absence of this G6PD deficiency, that is a defective enzyme, enzyme which is belonging to the hexose monophosphate I actually HLP shunt is the enzyme deficient, is the G6PD deficiency, results in this hemolysis. I hope you all remember that what we have discussed in G6PD deficiency from our workbook. Actually, we have discussed about the various type of the cells you will be getting in this G6PD deficiency, that is the blister cells, helmet cells, bite cells, and also what I told you. Okay, I told you in my questions. Okay, regarding this, I gave you one question in the test-based discussion also, and we have discussed about the Hughes bodies is seen in G6PD deficiency. Okay, so I told you about bite, blister, hemicose cells, and helmet cells. Okay, so this is the thing you should remember. Yes. And another question, actually, it is more of like a clinical thing, but still, actually, what this question in Samter's triad of the asthma, which drug should be avoided? It is a thing, very important thing, aspirin. Yes, the same thing actually we discussed in our workbook in pathology sessions. I told you about this Samter's triad, that is aspirin, asthma, and the nasal polyp. Okay, so if you could remember, like in your test discussion, in your test also, I have given you similar question. Okay, in your test also, I have given you this similar question. That is the same things, similar kind of history I have given you. Okay, the female with the nasal polyps and osteoarthritis, and she had medications. And what will be the disease which is precipitating the wheezing and coughing? The similar things which I told you in our test-based discussion, and exactly the same thing was asked in your exams. And this is something like a female presenting with their body mass index of 30. And also some were saying that there was a history of gastric carcinoma, that is under the brackets. But basically it is a lesion, is a female with the obesity, and in the lesion in the cervical region. Okay, so this is a case of a metabolic syndrome. So the marker of the metabolic syndrome in the cervical region, especially in a female, you have to think of this acanthosis nigricans. Okay, this is a marker of the metabolic syndrome, okay, especially in the cervical region. So the history is like a female with a BMI of 30. Okay, so you have to think of acanthosis nigricans. Okay, this also actually I have discussed about this acanthosis nigricans when I am dealing with this carcinoma stomach and the paraneoplastic syndromes. Okay. The other question, actually, again, it is from the glycogen storage disease. That is a child with exercise tolerance, muscle pain. The enzyme deficient is muscle glycogen phosphorylase. The other question is, and this is the same thing. Actually, I have discussed with you when we have dealt with this glycogen storage disease, and I told you about this myopathic type. That is the Macrocytes type 5 glycogen storage disease, where the enzyme deficient is muscle phosphorylase. Okay. And the same thing, the another thing, one cell communicates with the other cell through chemical messenger. This type of action is called as, yes. The guys, I hope you remember that while discussing about the cytokines, I mentioned you about this different types of this cell communications. Yes, you remember our workbook notes. We can discuss about the autocrine, paracrine, and endocrine effect. Yes. The autocrine effect is nothing but the one cell secretes the chemical substances that acts on its own cells. Okay, these chemical substances acting on the own cells is called as the autocrine. Endocrine is nothing but the cell secreting the substances, say for example hormones, that acts as a distant site. That acts as a distant site is called as the endocrine. And what is paracrine? That is one cell secreting the chemical substances that communicate with the adjacent cells is called as the paracrine. So here from the example, actually you can remember that one cell communicates with the other cell through chemical messenger. This type of action is called as paracrine. Yes, paracrine. Okay, so guys, actually, there are some other few more questions. Actually, like this putty kidney was asked, putty kidney image, and some are saying that it is a staghorn calculus. And these things also actually we discussed about the putty kidney and calculus, staghorn calculus, putty kidney during the tuberculosis I discussed with you, and staghorn calculus also was discussed. Another question which was asked is actually they were saying that they're given the image of Duchenne muscular dystrophy. The muscles were atrophied and showing this dystrophic changes, and about the Duchenne muscular dystrophy, and fibrocartilage image was given, and that also was asked. So if you could carefully see and analyze about these questions, okay, so most of the questions are like actually there are straightforward questions. The proportion of the straightforward questions is somewhat like less only, okay, but the clue, the application aspect, okay, the application aspect, and once again the integration, okay, the integration of pathology, biochemistry with the medicine, okay, so all these things are integrated, and the integrated things are there, and still the image based things carries the most important thing, especially in the hematology based questions, okay, CML, sickle cell, and all these things actually we were asked to interpret the images. So this again stresses the importance of the how important is the interpretation of the image-based questions in your exams. Okay, so with these things, actually, please, if you have any doubt regarding these things, you can put it on the chat box. Okay, you are welcome to change the options. So it is a purely a recall-based sessions, and actually we are happy to say that most of the things actually you could see from the screenshots taken from our workbook. Most of the things are taken from this workbook based things, and we hope again wish you all the best, and wish you advance congratulations to all of you for a successful career. Okay, so it's Dr. Vimal signing off. Thank you very much.